Welcome guests, welcome panelists, welcome to those in the future that will find this archive here. Good evening, good afternoon, good morning, depending on where you are in the world. This is the third season of the DHIT Frequency, brought to you by the Digital Health Institute for Transformation. This is a place where we come together as health transformers, innovators, problem solvers to talk about the best practices, next practices, and advancements in the field of digital health. I'm Michael Levy, DHIT's president and co-host today, and co-hosting with the great Kathy Malice here for season 3, the associate CEO of the Hospital Center of the University of Montreal and head of innovation in AI. Kathy, welcome, and what pleasure
Thank you,
it is
Michael.
to have you.
Same here. I'm very excited to join you, Michael, in this third season of DHIT Frequency. I thank you in my name and my institution. Sharing what innovators have accomplished to improve health and the well-being is crucial, and thanks again for this invitation.
Absolutely. Of course, besides getting to spend, a number of months every other Friday with you, Kathy, and spending quality time together, I'm really looking forward to the discussions that are going to be explored on this season, starting, of course, head on with an alignment with Mental Health Awareness Week and tomorrow's Global Mental Health Day. We're gonna talk about mental health today and the challenges and potential opportunities for innovation and change in particularly with the digital bent. But the other topics that we're going to explore are naturally as broad in a lot of respects, but as important, from pediatric care to aging in place to precision medicine and consumer care. So along with our subject matter experts and our innovators, I imagine us to have a wonderful third season of DHIT Frequency, and I'm excited to and appropriately so focus and start on mental health, considering where we are as a community across the globe, going through this pandemic together, the acceleration of change, the realities of stress and impact to our lives. All of it's very real. How do we make sense out of it? What's our place in the world, and how do we envision that world in the future? That's what these discussions really are going to tease at today and going forward.
So we know that health we focus mostly health on the physical aspect, but health is a state of physical, mental, and social well-being, and not merely the absence of disease or focusing only on one aspect of health. In today's healthcare system, we tend to focus, like I said, mostly on the physical aspect. But mental health, from prevention to cure and care, is not enough spoken about, discussed and tackled in today's society. And as you said, Michael, innovation in this sector is essential, and we'll see this today with our panelists. Exactly.
Look, before we jump into our panel discussion and shine a light on our esteemed panelists, I want to first shine a light on Kathy Malice for a moment, and perhaps have an opportunity to share, Kathy. Give us a sense of your role, responsibilities at CHUM. What pathway, road did you travel to kind of assume this position, get to where you are, and what keeps you motivated? What keeps you going?
So I'm Kathy. My role here at CHUM today is I'm the associate to the CEO, responsible of the Pole of Innovation and AI in Health. What led me to that? Well, I started as a clinician. I'm a speech-language pathologist, graduated from University of Montreal, and did clinical research from day one. And I discovered the passion of managing knowledge and innovation to improve what we do towards our patients. So management was something that I found very valuable in offering the best and excellent care for our patients. So this is where I developed an expertise in management. I even started a startup on my own. So the entrepreneurship, so crossing clinical research, teaching, so generating knowledge and innovation to improve the care that we offer to our patients is key. So what motivates me is innovation that really has an impact on society and our population.
Wonderful. Thank you so much. I'm going to be tugging at Kathy over the next few months and helping our audience, our community abroad, know the scope and breadth of both your touch and your mindset. The reason why we invited Kathy and continue to work on a relationship and partnership is the alignment and the continued kind of perseverance to that ideal state, perhaps. Well, thanks for letting me shine a light on you, Kathy. Now I'll turn our attention to our esteemed guest today, and I'll start with Dr. Isabelle Desjardins, Chief Medical Officer for the University of Vermont Medical Center and psychiatrist. Held many roles across the university system, from medical director of the, I believe, Seneca Center, which is a outpatient, inpatient psychiatric treatment center, as well as vice chair of clinical affairs for the Department of Psychiatry. Thank you so much, Dr. Desjardins, joining us today.
Thank you for having me. It's a pleasure to be able to contribute to the discussion.
Thank you. We also have Jeffrey Carey, a good friend and colleague as well, CEO of Lifespan. Actually, of note, one was an awardee of our last DHIT virtual incubator last season. So congratulations on that, Jeff. I don't know if I had an opportunity to congratulate you. Lifespan is an initiative dedicated to delivering personalized and measurement-based mental health tools and services for communities that lack such. Thank you for joining us, Jeff.
Thank you. Pleasure to be here.
And then we have Marina Massingham, CEO of AFRED, another close friend of DHIT. Marina, you joined us back in November 2019 for DHIT Summit. So thank you again for sharing time with us and your expertise. AFRED is a solution that uses AI to learn from clinical data of thousands of patients to help tailor individual treatment, significantly reducing the time it takes for a patient to reach remission. So thank you for joining, Marina.
Thank you very much for the invite. I'm looking forward to the discussion.
What a group. Excited to jump in. So before we do that, I want to encourage participation from the audience by using the Q&A section to send questions over throughout the discussion. We'll try to stay on top of them and interweave them as they come through. And depending on whether we have time, we'll pick up some of them to answer towards the end of our program. So let's go on with the first question. We'll start with Isabelle. So from your lens, give us a sense of what you're worried about right now. We know both US and Canada, the rates of mental health, unfortunately, are effectively the same and high. What's going on, according to you?
So, just for context, I have the privilege to serve here at the University of Vermont Medical Center. This is the only academic medical center in the state of Vermont and upstate New York. And I serve as the chief medical officer, and the hospital has 450 beds. And we are responsible for the tertiary care of the region. What I'm seeing in the the chair I sit in is that there is a lot of talk about mental health issues, but very little meaningful progress. And there is little progress in advancing the real hardcore outcomes, and things are getting worse. There are a lot of dissipated activities that are not unified. And there is a little bit of learned helplessness in the system as well. And there is absolutely no accountability placed on on leaders like me in the position I am. No accountability placed on leaders like me to deliver on improvements of outcomes in mental health. If it doesn't start at the top, it's never going to happen. And I think that that's one of the key elements of disconnect that we're seeing. There's a lot of talk, a lot of energy, but no organized and framed, hardwire, systematic accountability in the system to make things better.
Do you think that's, I mean, that's I feel that statement. I think that is, you know, I mean, it actually just gave me chills because it's putting a level of responsibility and accountability to the system that is supposed to govern care. And you're pointing out a major, flaw in our system is, you know, so you have that knowledge, Isabel. Waking up tomorrow, what is the activity? What's the call to action?
So I think it starts with the expectations at the political level. Like for example, in a hospital like the one, I mean, believe it or not, I'm a psychiatrist. I've lived all my career delivering psychiatric care to the most vulnerable and the sickest individuals with primary psychiatric illnesses. I am now a chief medical officer of an academic medical center, and the mountain is so big that I can have very little impact just as myself in advocating for a different approach to mental health outcomes, because the pressures come from regulators. So there are a set of regulations, a set of standards that are placed and established by the federal governments, the state governments regarding the delivery of healthcare. And the drivers of performance for hospitals, for health systems, are really not aligned with mental health outcomes at this point in time, at least in the United States. So it really needs to start there.
Is there a lack of understanding between the connectivity of mental health and physical health, and how dependent one is on the other to an extent?
I think it's people understand it, people live it. I mean, we all live it, we all see it now during this COVID times. I think there is a learned helplessness, and a lot of leaders really don't know what to do exactly because the problem is very broad, it's very multifaceted. It's not one specific cell that you can target and change the DNA of, like in other diseases. There is a societal component to it. It really, the different tactics need to target a very broad span of the population with different types of interventions. It's multi-layered. So I think it's a feeling of not knowing exactly where to start, and also a little bit of learned helplessness, and still a lot of bias against mental illness.
Well,
so
I guess,
Isabella, we have one question too before we segue to the next section. I'm sure you thought of one initiative where you could align impact assessment on value, which is improving mental health or well-being of our patients, but also employees and our staff. One thing you thought about that you implemented on your level or with your colleagues, what would it be? One action to align impact on value.
So very interesting question. Two pieces of work that we're currently doing at the University of Vermont Medical Center, where I have an impact. Number one is to embed an ethicist, an institutional ethicist, in every single layer of the organization to really ensure that we are aligning our decisions, our policies with our values and our mission. And our stated mission is also aligning with the need to provide high-value care, and high-value care being defined as safety, quality plus quality over cost times experience, and experience being broadly defined as the experience not only of our patients and families, but also of our employees and our trainees, our learners, as well as our community. And that's where the specific wellness outcomes really come into play. And we are intentionally moving away from the traditional unilateral quality construct in healthcare, particularly in the United States, and moving away from that to pivoting to a high value care construct where we intentionally impose the task on ourselves to put our limited resources on high impact, high risk, and actionable activities and priorities. So through that, I think that there is definitely an alignment that is shaping to addressing the issue of well-being, resilience, mental health, and the discriminatory bias that has been traditionally present in that kind of pathology or medical illness, at least in the United States. So I see that is one area where I can have an impact in intentionally aligning and pushing and forcing the conversations and including specific mental health related outcomes as a measure of success for our organization.
Yeah, makes perfect sense. And I think getting to, and I'll pull in Marina and Jeff here, getting to the idea that this is a massive a mountain, and you're sitting at the top, and you need the resources, the extensible resources, the many across the ecosystem. Naturally, with the help of innovators and entrepreneurs that see the gaps and the holes at a granular level within the system. This ties perfectly into Marina and Jeff's initiatives, and so turning the focus, Marina and Jeff, both of you lack medical and psychology degrees, but yet you both are dedicating your time and energy to solving pieces of this massive problem. Why? What? Let's start with you, Marina. What's going on? What do you see, and what has you so charged to spend your life dedicated to what you're doing today?
Thank you. That's a great question. So as you've touched upon before, obviously during this time of COVID, we're seeing the mental health burden rise rapidly in the populations within North America and around the world. We're very motivated to do our part in helping to ease that burden and to help patients to get to remission and have better outcomes, starting in North America. But my motivation originally comes from a very personal place. So, and I have permission to share this. My younger brother was 17 when he first started showing symptoms of major depression. He was 18 by the time we managed to get him treatment, but he was 28 by the time we managed to get him stable. Part of the problem was there was no way for the doctor to understand or personalize treatment selection down to him as an individual patient. First-line treatments are pretty much equally effective at the population level, but that's not true at the individual patient level. So what we saw was a trial and error approach to treatment. He would try a new treatment, that trial would fail, he'd go on to the next and the next. And those 10 years were very difficult for us as a family. They were incredibly difficult for him as a patient. And both myself and the entire team at AFRED are very motivated to tackle this trial and error approach to treatment, which was the same 20 years ago as we see today.
Thank you, and I mean that's a trial and error, almost and when we look at the mental health resources and the lack thereof, as the demand of resources go up, the actual resources we have are reducing. The trial and error or the triaging is a particular point of pain that supports building efficiency into the system, right? And making the most out of the resources we do have by really prioritizing the treatment options for the specific individual. So I could imagine the value there. Jeff, you have a slightly different slant on your initiative from a less of a triaging, more of a direct care, kind of caregiving, resourcing, and supporting the specific individual with that end resource. Can you share, and we can get into that effort a little bit, but rolling back, share what motivates. Why are you dedicated to this, and why are you waking up every day spending your time and energy on this subject matter?
Well, thanks a lot, Michael, and thanks for that question. Like Marina, mine came from a very personal place. And, I started this journey because of the death of one of my daughters. She passed away from an autoimmune disease, but she left behind 4 young boys. And all 4 of them were neurodiverse. One was autistic, and the other 2 had ADHD. The other 3 had ADHD and behavioral problems. And so it took me on that journey to see how I could meet those unmet needs with them. And I quickly found out that there are really gaps in the systems that's there to support them. And so I started out I've been in technology for the last 40 years. And so I started to go back to my roots in technology transfer and technology to see where I could find evidence-based practices that would help them. But I quickly found that along with being a spectrum disorder, it goes from one gamut to the other, and I couldn't boil the ocean. And so I decided to look at social and emotional learning and teaching them the foundation of emotional self-regulation. And so I started with that diverse set. And it took me on a journey to building out game-based interventions. But fast forward to about 2.5 to 3 years ago, my youngest daughter was doing well in school at first, in her first year, but then she started to decline and she flunked out in her second year. And little did I know, because she didn't want to confide and there was a stigma attached to it, especially coming out of a minority community, that she was having mental health issues. She was having extreme panic and anxiety, and it caused her just to not go to class anymore. And so I wanted to see where, it hit home a second time, and I found out that she was really contemplating suicide ideation, and I didn't know it. And so I would have lost a 4th child. And so it took me on this journey to look at mental health specifically. And as I looked forward, really focusing on college students, it exposed huge inconsistencies and gaps in the healthcare system. So I'm driven because I'm from an underserved and marginalized community, and I see the pain every day. My family is still there, yet these marginalized, underserved communities lack sufficient access to the care that they so desperately need. And they should have that care, regardless of their socioeconomic lot in life. And so, it's unacceptable to me that many of them, especially in the minority and underserved communities, are just viewed as collateral damage. So I'm driven to disrupt and bend the curve of healthcare as we know it today. And, we do that as a community. And so I'm driven to make a mark and do what needs to be done to change the face of both mental and primary healthcare in this country and on a global basis.
Thank you, Jeff. That's big hug, number one. Both Marina and Jeff, thanks for sharing very personal stories. I think we all have an element of this in our lives, because mental health is not an individual's own journey. It does connect into our family and our respective friends and colleagues, et cetera, as we are all connected in this system of life together, as you help your family and your friends with these various realities.
Michael, do you want to take a question from the public, or do you want me to move on to the next?
Yeah, we can grab one from the public. That's fine.
Yeah, there's a question here from Sudhakar Koshik for Marina. What is the state of the art in personalized mental health issues, and are they different from PDD? That must be, or Ahonia, I'll come back to major depression disorder.
That's a great question. So the challenges of treatment selection go beyond into other areas of mental health, beyond major depression, but also into other areas even of health generally. So what we're trying to tackle is a really big problem of personalizing treatment selection. And we've decided to start with depression because it's very well recognized. But really understanding the variables that drive individual response to specific treatments available today is a major issue that definitely goes beyond depression alone.
Thank you, Marina. So again, I would like to thank you for sharing your personal experience, Jeff and Maria. It's very inspirational and touching. So thanks to you. So let's go back to maybe a question for Isabelle. So like Jeff and Marina, Isabelle, I understand that you have had your hand in developing a digital health tool, which I believe it's a suicide risk simulator to help non-mental health providers assess patients who are experiencing mental distress. Tell us a bit about that and your experience.
So thank you. Yes, I do have that too as a area of interest. So I've been an inpatient psychiatrist for 20 years, and I've had the unfortunate experience of having a few of my patients die by suicide. Very devastating events for a doctor who really tries to help very much their patients, devastating. And one of those events was happened in the hospital a number of years back. And following that event, I mean, it was tragic. You can imagine. Yeah. It really motivated me to start thinking about what lies in suicide risk assessments done by psychiatrists, what lies in suicide risk assessments in the community, what's the evidence behind it, and tried to find a way to have an impact beyond the individual relationship I had with each of my patients. So that's where I started to think about, would there be a way, looking at all the suicide risk assessments that were there, which was 10 years ago, which there was very little, started to think about, is suicide and suicide risk really a byproduct of depression, or is it a thing in itself that is independent from depression? And I believe that erroneously, the field has seen suicide risk as a byproduct of depression and has missed the opportunities of screening for individuals who don't necessarily have a diagnosis of depression first, but continue to have and remain with suicide risk because of fundamental drivers of suicide, like shame, sense of not belonging, inability to cope in the moment, and a loss of agency within oneself, which are not really elements of anywhere that are described anywhere in the DSM-5. So coming back to the tool that we created, we decided to use a neural network model to replicate the critical thinking of expert psychiatrists who are evaluating individuals in emergency rooms for the risk of dying by suicide in the next 72 hours. So for example, my question was, what makes a difference in my mind when I'm sitting with a Caucasian 55-year-old veteran with alcohol use disorder who just got divorced, and I have two of them, and I'm evaluating one of them, and I'm sending him home, and I sleep at night, and the other one I'm putting immediately on constant observation in the emergency department. So we tried to drill down on what are the drivers, the cognitive elements of critical thinking of the experts, and looking at how we can extrapolate this and create an assessment tool that could be used by non-psychiatrists to make accurate assessments of immediate risk of suicide in the field, and see if we could have an impact in doing so. So there is potentially a lot of applicability to it. It's a learning model as well. So it's built on a neural network. So it really learns as it goes. And given that suicides are not as frequent when you look at the global population, and that it's hard to obtain suicide death data, you need a really large number of people to really look at the specific outcome measure that we're studying. So yeah, so that's what we created. So we have that model in place, and we have translated that into a digital tool.
Very impressive. Thank you so much for sharing this. So to all, I have a question. In 60 seconds, what has been the most difficult part of developing your solution? So let's start by Jeff.
Thank you for that question. I think the most difficult part has been, as a pure startup, we want to get it right. We don't want to be an also-ran. There's too many solutions out there that are not steeped in evidence. And we want to understand, during this time, it's been because of COVID, our primary customer base and customer segment were our universities and students and CAP centers. And getting to them to get voice of the customer has been the biggest driver, the biggest challenge that we've had. Because we need to get voice of the customer. We need to reach a product market fit. And we don't want to be a field of dreams product, build it and hope they'll come. We want to address the hair on fire challenges and have those solutions based in evidence and scientific evidence. And that's been the biggest challenge, because we need to test out our hypotheses.
Yeah. Marina, what was your biggest challenge, the most difficult part of developing your solution?
I think that's a great question. So our solution has two parts. We have treatment management, which is designed to help particularly non-psychiatrists, so family doctors, to understand where the patient is on the disease cycle and what to do next at each stage of the treatment journey. And we are completing development on our AI model for treatment selection, actually the same one we're competing with in the Global IBM Watson AIX Prize. And both of these types of technology are quite complex, but we really needed to address the challenge of making them accessible. So one of our key challenges has been building a front-end user experience, both for patients and physicians, that is simple, frictionless, engaging, and requires very little time to train a doctor and no time to train a patient.
Yeah. Keeping it simple and silly it's always the most challenging part, right? Because keeping something very intuitive is a challenging part.
It's worth it. Otherwise, people won't use it. You can have the greatest tech in the world, but if you don't make it usable, it's not going to go anywhere.
Definitely. And again, a last question for all three, and I'll start with Isabelle. What has been the most rewarding part of you finding innovative solution to respond to the needs of your population, your clients, your patients? Isabelle.
For me, it's been the ability to have an impact beyond the individual patients that I treat as a psychiatrist, and really see the experience that I have gained over the years used to have a broader impact. And the other piece is really about how people feel so connected with the thinking process that is behind what I've created, And when I tell the story and I see people's eyes lighten up and say, yes, I totally agree, I get it, it makes a lot of sense, it's very, very rewarding and really stimulating and motivating to continue trying to overcome the zillion barriers in implementation.
Jeff?
So for me, it's really the realization and coming together, rather organically, I might say, with so many industry visionaries like my colleagues sharing this panel, so many that are like-minded and like-hearted, and hearing from potential customers when we present our vision to them that we're actually on the right track. We're moving in the right way, and then really realizing, that the undercurrents of digital transformation in healthcare and mental health care specific is both strong and is actually at the tipping point.
And Marina, what's the most rewarding part for you?
I would agree with Jeff. It's very inspiring to be part of a new, I would say, a movement on mental health care. I think COVID has really shone the spotlight on mental health burden right now, and I think it's great to be having these kind of discussions. If we don't talk about it and the issues that we face, we're never going to get to roll out of the great solutions and the great tech that's being developed here and around the world. For me also, it's very rewarding to see the impact on patients themselves as our tool has been used and tested. I guess I always have my brother in the back of my mind. I have our family. I don't want to see more patients and their families suffering. So to actually see our tech in use and helping to alleviate the suffering patient by patient is hugely rewarding as well.
Yeah, Marina, you brought up COVID-19. First off, thank you. I can imagine. I most resonate with the rewards associated. But you mentioned COVID-19. I'm going to direct this to Kathy and Isabel. Considering both of you are operating and leading large health organizations that both are dealing with COVID, perhaps some in the first wave and now in the second wave, but nonetheless, both staff and patients, you've got to see a before and after or during. What does mental health look like now through your lens as an administrator of these systems and managing the realities of the mental distress that we're feeling today? Let's start with Kathy.
Oh, I wanted to propose it to Isabel.
Okay.
I'll go after. Sorry, Michael.
No worries.
So in terms of what we've seen in our system, in terms of the specific demand for inpatient psychiatric treatment, for example, we have not seen a lot of change, and we have not seen a lot of a change in volume or a change in demand specifically related to COVID-19. However, we have seen year over year a gradual increase in the need, the demand, and the severity of illness in the past 5 years, with a mismatch between the demand and the availability of skilled resources. So that we have seen, but not specific to COVID-19. In relation to COVID-19, my observations are that the entire system, everybody is fatigued, tired, deprived in some way, longing, where I'm seeing there is most distress is in people realizing that they need different skills to be more resilient with the unexpected. I think that this is really a human condition issue. In the North American world, I believe, particularly, where there is a little ability to find different ways of coping in the moment and over time. and it requires somewhat of an active teaching of how to go about it, which has been fascinating to me. So these are the observations that I have had in the past 6 months, particularly with the physician community, the clinician community.
Thank you. Kathy, do you have a piggyback or alternative?
Sure, I'll give a bit complimentary to Dr. Desjardins' response. So we since the beginning of the crisis, we anticipated, like all of us, that there's going to be the stress and anxiety, not only and fear, not only with our patients, but our CHUM community, so staff, clinicians, researchers, managers. So we anticipated that, and I'll go more concrete. I'll leave concrete actions that we did to actually monitor and address this potential anxiety and stress that we measure today is present. So number one, we introduced an auto-assessment tool of stress and anxiety for all our staff to actually monitor themselves. It's for them, and if they do have above average stress and anxiety level, trigger them to services that the institution offers. So we created during the first wave and still in the second one, a psychosocial cell that is deployed to support not only individual, but this distress in a team. We also have the traditional support on an individual level, on a psychosocial level. So this is something we deployed specifically for COVID, and we're maintaining it in the second wave. And what's cool in the second wave is that we approach our University of Montreal psychology clinic if there is a high demand of our employees for individual interventions. We're working with the university to deploy even students and the clinicians to support if the increase of stress and anxiety on an individual level is observed. For the patient, in Montreal, and I'm sure in the United States, we shut down hospital for visits from families and friends to the patients. So it generates isolation and solitude. So we deployed a project called CHUM Connected. So a massive deployment of smartphones and tablets to reconnect patients with their family. And we created a specific team close to the clinicians to give news of patients to their families. So, usually units and clinics do that, but with COVID, they were overwhelmed and new protocols, new teaching. So we did a SWAT team of nurses and volunteers that their task was only to give news for the families and supporting end of life for patients that were dying. So these are concrete examples of what we did to actually tackle stress and anxiety and fear of this unknown disease for our patients, but also for our staff and collaborators.
That's fantastic. Let me tug on Marina and Jeff for a second. Marina, you and Jeff, both of you, similar questions. You're running your teams now, and you're servicing your vision and your customers. How has COVID impacted that narrative for you, and how are y'all maintaining a steady, persistent, mental state, if possible?
Marina, would you like to take that first?
Sure. Good question. So from a practical standpoint, when Quebec went into, lockdown is how we could describe it, in mid-March, we pulled all of our clinical assistants and research assistants out of the field immediately. This did make some routine tasks more difficult, those that would have normally been done face-to-face. However, I'm very proud of the resilience of the team. We managed to find alternative ways to do virtually what we used to be doing in person. I think what was also good is our tool is 100% virtual anyway. So as doctors adapted and quite as Kathy mentioned, hospitals shut down, patients couldn't see their physicians face-to-face, physicians moved into a virtual appointment setting, and our tool was able to support them in that setting as well, which was great. And in fact, it's been very helpful for physicians, particularly family doctors. So here in Canada, 90% of patients will get treated at the family doctor level. And they were managing a lot, so they found it very useful to be able to effectively remote monitor and manage the increasing levels of patients that they were seeing at that time.
Fantastic. Thanks, Marina. Jeff, quick response from you.
Yeah, sure. So, I feel like I'm the poster child for testing resilience. And about 4 months ago, I lost my brother lost his battle with COVID. It was really difficult for us because there was no closure. From the point that we saw him, that he was in the hospital, I texted with him, and he couldn't go to see him because New York was on lockdown. When he passed, couldn't go to a funeral, couldn't have a funeral. And so we had to join Slack or Skype and do a Skype funeral with 2 or 3 people, no more than 10 in the direct audience and 122 people online. And that was my goodbye. And I still keep his voicemail in his last text saying I'm okay on my phone. So that's my last contact with my brother. And right now, close friend of the family in Arkansas, who my wife's been close to since grade school, is now in a medically induced coma. And she is 100% breathing through a respirator. And so as of last night, she wasn't doing any better. She wasn't doing any worse. But it's really hitting home. And it's difficult for me to keep a positive mental state and to keep on point and to be the cheerleader and the advocate for mental health. At the same time, it gives me hope because in the face of all the sickness and death, I'm still standing. And what it's done is it made me come to a realization and an acceptance that I have PTSD. And so now release the stigma. And so, I'm proud to say that, like Hair Club for Men, I'm not only the president, I'm a client. When we developed, we're a pre-product company, and we serve the academic community. It's been a challenge doing customer discovery. We won an NSF I-Corps grant to do 8 weeks of customer discovery. Instead of traveling the country, we had to do it remotely, but we were able to talk to over 150 to 200 potential customers. And so it stretched our capacity and our creativeness in order to do that. But I say all of that to say that we see the light at the end of the tunnel. It's been a challenge, but the team that we have is pressing forward. And I'm encouraged that at the end of the year, we'll be putting a product out in the market that's really going to help to bend the curve of healthcare. As challenging as it has been, it's been equally rewarding.
Well, again, Jeff and Marina, thank you for sharing this with us. Jeff, I think everyone on this webcast shares in my sentiment. You are resilient, and we appreciate your persistence, considering and in spite of. So thank you, Jeff. We're at this at the period of the episode. This is a new kind of a function in the DHIT Frequency for season 3. We're gonna ask a few questions, kind of rapid fire, if you will. One word or one sentence question, so it should be pretty quick. Let's start with you, Isabel, if you'd like. Give us this is what do you know that we should know? Give us one thought, one stat, one thing that perhaps is not well known that you would like the audience to know about regarding mental health.
There is no mental health related outcome in any of your hospital executive dashboards across the United States.
Wow.
It's all related to cardiac mortality, sepsis, hospital-acquired infections, infections related to surgeries, hip surgeries, knee surgeries. That's where it's at.
Wow.
Wow. Unbelievable. Thank you, Isabel. I think all of us will be chewing on that one for a while. Jeff, how about you?
Depression is more common than AIDS, cancer, and diabetes combined. And those that are impacted are 4 times more likely to experience a heart attack.
again, a tough one to swallow. Marina.
Depression is the leading cause of medical disability worldwide, according to the WHO. Truly is a global problem.
And to that point, this is the next question, and we'll start with you, Jeff. What's your reaction to this stat in one word? More than half of U.S. counties have no practicing psychiatrists. 37% of counties have no psychologist, and 2/3 of counties have no psychiatric nurse practitioners. Non-metropolitan counties have an even higher likelihood of no accessible providers.
Could I use 3 words?
Yeah.
Unacceptable, dangerous, but there's an opportunity.
Thank you, Jeff. Marina?
I think this is deeply concerning. I think it underscores the need to make the best use of the resources we have by equipping those resources to make the best possible care decisions as efficiently as possible, and to look at the tools we have available today to see how access can be expanded. We have the technology. We need to make sure it goes into use.
Thank you, Marina. Isabel?
It totally reflects my reality as a psychiatrist. I'm not surprised. And it really points out to the fact that we need to continue advocating for more medical students going into psychiatry residencies, to advocate for graduate medical education, to expand the limits to psychiatry residency training programs, and increase the psychiatry rotations in other medical specialties like emergency department.
Thank you, Isabel. We're gonna start with you on this last one as well. I'm sure we could spend an hour delineating on this, but in your best effort, one sentence, if you had a magic wand, what's one thing you would do to solve the mental health crisis?
Push telehealth, push solutions that really connect people, that make people feeling less isolated and increase their sense of belonging. Interventions in schools early on, CBT, mindfulness, meditation, resilience training, schools, universities, that's where it's at.
Awesome, thank you. Jeff?
So my magic wand would be if we could build a platform that ties together uncommon communities with common concerns or needs in order to spawn awareness of and access to and sharing of critical resources as necessary to advance the healthcare and wellness of individual communities on a global scale.
Thank you. And Marina?
I would really like to see mental health become a higher priority at the government level, to go back to something Isabel mentioned before around politics, the health system level. We really have the technology here to make a tremendous difference, but we need prioritization and resources in order to make that difference happen.
Absolutely. Thank you, Marina, Jeff, and Isabel. And thank you to our great partners. Kathy, thank you for co-hosting. Brian.
Thank you to the Hospital Center of University of Montreal and the Government of Quebec. As the coolest hotspot for innovation, we're proud to have the Government of Quebec as a disruptive partner. We'll now hear from Marina as she shares a case study about a doctor-patient experience using AFRED.
Thank you, Brian. So, in the interest of time, I'll make this as brief as I can. So our tool does, one of the things it does is treatment management. So we have a patient physician app. Patients fill in questionnaires, standardized questionnaires used in the assessment of mental health today. And those results get charted over time. There's more to it than that, but I'll keep it brief. We had a psychiatrist who was following a patient, and I have, again, permission to talk about this, in her 60s, early 60s. She'd been on a very strong anti-anxiety medication for a number of years, and a medication that really wasn't a good idea for her to continue to be on, particularly as she aged. So the goal of this treating doctor was to wean the patient off medication. Now, normally what would happen is you'd give the patient the instructions, which in this case were quite complex, so almost taking a quarter of a pill off every week. Wait 1 or 2 months for the next appointment and kind of cross your fingers a little bit until you next see the patient. But what this doctor was able to do was to get the patient on the tool so that he could regularly chart her progress over time. Now, this patient was doing well, but one day she phones him and wants to see him immediately. She's feeling very anxious. She's had a spike. Happens that this doctor is actually in New York, not in Montreal. He opens the app with her, and together they're able to discuss her trajectory, how she's been doing. He's able to demonstrate to her that, in fact, yes, she has a spike, but it isn't as bad as the previous anxiety she's had earlier in her treatment cycle. They then can quickly get to a discussion around causality. They have that discussion. Turns out the patient hadn't been sleeping well for the last couple of nights, and that was quickly established as the cause, and the patient felt reassured. Ultimately, the patient continued to use the tool and got to full remission. The reason I like this story is I think it touches on a number of themes that are important, which is having patients empowered in their own care and able to understand how their data is being used. Convenience for the doctor. He was obviously in New York, didn't have a lot of time to talk to the patient, needed to understand where the patient was very rapidly, and be able to focus the discussion with the patient on solutions which engage the patient in their own care much more effectively. And finally, we did what we always aim to do, which is to see the patient ultimately get to remission. So better outcome for the patient.
Well, that's fantastic. Thank you, Marina, for sharing that case study. And again, thank you, Marina, Jeff, and Dr. Desjardins for being dedicated to our mental health crisis across North America, U.S., Canada, and spreading innovations and your focus and your motivations to those who need it most. Really appreciate it. Kathy, phenomenal first episode with you. Many thanks again for co-hosting. I do want to draw attention to, in 2 weeks, we will be carrying on DHIT Frequency Season 3 with a focus on aging in place. We will start opening registration for that as early as Monday, and our panel will be announced as of middle of next week. So please stay tuned for that. Register, share, and any last parting words, Kathy?
That was amazing, very inspirational, very touching, and we need people like you, and I'm sure our participants, to change the world for a better place, for better health and well-being. So thank you, Michael and DHIT, for this invitation, and to our panelists too.
Thank you so much. And to the questions that were asked that were not answered, we will try to reconcile offline and share back as best as possible. So stay tuned. Thank you all. And on behalf of DHIT CHUM Quebec, we are tuning out. Cheers.